to cover for exam. The overview of my lecture, I will talk briefly on the classification, the indication, the contraindication, preoperative evaluation and counseling, techniques and conclusions. So everyone knows that when you talk about cholesteatoma, it is a misnomer. There's a keratins at the abnormal place, and it consists of matrix, perimatrix, and the contents of the cholesteatoma is cystic, which is include the anucleated keratin squamous epithelium. So the matrix consists of keratinizing squamous epithelium, and perimetric is a fibrous tissue with the inflammatory cells. So everyone need to understand the previous years there is a short note on congenital cholesteatoma. So when you say congenital cholesteatoma means that you need to have a criteria. So the criteria is patient doesn't have any surgical procedure, there is no history of inflammation, there is an intact tympanic membrane, and there is a presence of keratins medial to the intact tympanic membrane. So you can see here there is a keratin pearl medial to the tympanic membrane following exploratory tympanotomy. How about the acute cholesteatoma? So acute cholesteatoma, we normally see the patients in the clinic, and it can be divided into primary acquired cholesteatoma or secondary acquired cholesteatoma. So when you talk about primary acquired cholesteatoma, it occurs as there's a presence of retractions or CAT. I give you an example. Yesterday patient, right? Encik Azlan. This patient had active cholesteatoma. Patient doesn't have any history before, and there is only eustachian tube dysfunction. So you need to think about the pusat space. Okay. The secondary acquired cholesteatoma is due to either infection, trauma, or iatrogenic, i.e. patient underwent laryngectomy and bromet. So if let's say write the long essay on cholesteatoma, unlikely it comes out in the exam because this is something can be tested in long case or in the viva. But they can ask you about cholesteatoma in a short case. Okay, the common. So the classification that you should also know is regarding CAO. CAO means cholesteatoma, the degree of atelectasis A, and the ossicular erosion. So why you want to choose this? This is a history. Another classification, 1988, divided into the site of the cholesteatoma, either active, partensa, whereby you can see there is a marginal perforation, or partensa 2, there is a presence of central disease. In other words, there is central perforation. Sana, Professor Sana is from Italy, so Dr. Raja Ahmad had 1 year with him, and they classified on the cholesteatoma at the petrous bone. So it can be either supralabyrinthine, infralabyrinthine, massive labyrinthine, or infralabyrinthine apical. So in this case, it's not used because it's not common to have only the petrous bone cholesteatoma. So Bilal 2012 classified based on TMC. T means that the tympanic cavity. M is an involvement of the mastoid and the presence of complication. So in other words, it looks at the site and the extensions of the disease. So this published in 2015, computed tomography stagings of middle ear cholesteatoma. So in other words, you can classify into TMC. That means tympanic cavity involvement, the mastoid cavity involvement, or complication. So how about the epidemiology? So the epidemiology, the incidence of acquired cholesteatoma range from 9 to 12.6 cases per 100,000 adults, and in children is slightly more, 3 to 15 cases per 100,000 children. So when you look at acquired in nature, it is more compared to the congenital. Or if let's say you think about the acquired types, the mean age is around 9 years old, and 7 to 10% of affected children has bilateral ear involvement. So in other words, when you have one patient with ear cholesteatoma, you should examine to the contralateral side. How about the pathogenesis? Okay, I will give you something history, but at the same time, I will give you regarding the reasons on the pathogenesis. So, theoretically, this is the old pathogenesis retraction pocket theory, epithelial invasions or migration, or squamous metaplasia or basal cell hyperplasia theory. So, in basal cell hyperplasia theory, keratin fills microcytes, buds, or pseudopod form in the basal layer of the pars flaccida epithelium. So the tympanic membrane has 3 layers: the squamous part, the membranous part, and the mucosal part. Okay, so it invades to the Prussard space. So Dr. Farhana, what is the boundaries of Prussard space? Imagine the coronal sections of CT scan. Laterally is a scutum. Okay, very good. Medially?
Neck of Malleus. Anteriorly is
supposed to be the neck and the head of Malleus. Superiorly is continuous to the tegment, and inferiorly it is open. Okay, so that is Prussard space. So now the theory is, when we look at the theory, it can be either the epithelial cell stress possible, if let's say it's congenital. But how does this cholesteatoma cause destructions of the bone? So one of the recent one, they look at the paracrine and autocrine interaction between matrix keratinocyte and perimetric fibroblast. In the first slide, I mentioned that there is a matrix and perimetric. So when there is a interaction between these two, so they release that the matrix keratinocytes produce these a lot of cytokines, and it is like a circle, and this causing a lot of tumor necrosing factor, and it is behave like it is as a malignant in terms of causing a disruption. So you can see a lot of interaction between these perimetrics and matrix. So they think that why they have this, because of upregulations of the cytokine, increase in the osteolysis, recruitments of the bone marrow mononuclear cells are multinucleated to form osteoclast. You know that osteoclast is the one that can cause destructions of the bone. And there is also receptor activator of nuclear factor kappa B ligands and matrix metaproteinase. So because of this, you can see that this upregulation causing the epidermal growth factor receptor transforming growth factor, and this can cause erosions of the bone. Now when you look at the pediatrics and adult patient, what the difference? So the difference is primary cholesteatoma is more aggressive. Often entire mastoid and mesotympanium involved, and early surgical treatment needed in order to have a clear, clean and safe mastoid surgery. So the factors that contribute to this pediatric versus adult cholesteatoma: in pediatric, rapid growth. There's problems in terms of well-pneumatized mastoid, because when you have well-pneumatized mastoid, the infection, the cytokines can go to any parts of the temporal bone, causing an infection. And there's also problem in terms of eustachian tube, because in pediatric it's not fully developed, and the eustachian tube is shorter and horizontal. And you can see, if let's say you look at this, it could be the presentation either in pediatrics or in adult patient. So you can see there is a retracted tympanic membrane. There is presence of crusting at the posterior-superior. So when you look at the CT scan, you can see here there is a soft tissue density inside the adductus ad antrum, inside the epitympanium, and inside the mastoid air cell. So when you see this one, you need to do a proper ear toilet. You remove this crusting and see whether there is a presence of cholesteatoma or not. So when you want to look at another pictures or otoscopy, you can see there is a perforation, there is a attic retraction pocket filled with the debris. So if let's say you have this debris, you should do a proper A toilet. So when you do a CT scan, you can see there is a soft tissue density inside this is mesotympanum. So I hope that my student able to differentiate between epitympanum and mesotympanum. So the cuts that you need to look for the mesotympanum is you look at the promontory, or you try to find out the tympanic membrane. Or in this case, you can see that this is the ascendance of the cochlea, this is middle turn. So this is a middle ear cavity. So in other words, the whole middle ear plus the hypotympanum filled with the soft tissue extends to the epitympanum. Okay. How about another otoscopic finding? So in this case, there is a retractions of the tympanic membrane. You can see there is a granulation tissue over the superior, posterior-superior. So when you look at this, you can say that this soft tissue, or you can say this is oral polyp arising from posterior-superior part of the EAC. I would like to assess further by examining this patient under the microscope, and if let's say patients allow me to probe, I will probe and try to look for where is the base of this oral polyp. So now you can look at the CT scan. So the CT scan shows there is soft tissue density inside the whole mastoid, the area of mesotympanum as well as the epitympanum. So now that's why I'm happy to have this lecture after Dr. Q presentation, because you already have a look about the normal anatomy of the CT scan for the temporal bone. So you look here, this is a basal turns of the cochlea, this is well pneumatized mastoid. Don't say this is a sclerotic mastoid, because this is a lot of bone. So bone, this is well pneumatized mastoid. So there is a soft tissue density at the mesotympanum. You can visualize clearly the tympanic membrane. And here you can see this is incudiomalleal joint. This is toward the facial nerve, and this filled with the soft tissue density. So you can see here, this is labyrinthine segment of the facial nerve. This is first genome. So what do you anticipate when you do a mastoidectomy or you do cortical mastoidectomy? You can see that there is anteriorly placed of the sigmoid sinus. So when you look at the coronal view, you can see here. So you can see here there is a very thin bone of the tegmen mastoidi. There's also thin bone here. So you can see here, this is at risk, this patient having a complication. So in other words, if let's say you have patient with symptoms of increased intracranial pressure, the CT scan shows this finding, you are quite safe, or you are safe to request for MRI with the contrast. Okay. Why you need to have MRI with the contrast? When you look here, you want to delineate whether this patient has a midline sheath. This is straight. There is a ring enhancement lesions over the medial cranial fossa. When you look here, this patient having a temporal lobe abscess. So in other words, if let's say in the exam, you have patient with intracranial complication, don't forget to mention patient next having nominal aphasia. Mention patient doesn't have any blurring of vision. There is no numbness of the face. So this can give you extra mark. So when you look at for the MRI, you look at the diffusion weighted image, and the sensitivity and specificity is 94%. So in other words, when you want to assess patient with cholesteatoma, there are two reasons why you want to request MRI. One, to look for the complication. When you have patient having symptoms of intracranial complication, or you don't want to do a second look surgery, the patient underwent uneventful first stage procedure, then 6 months later patient refused for second look surgery, then you can request for the MRI. So the MRI can differentiate regarding whether this patient had recurrence or residual cholesteatoma. So now we go to the goal of surgery. So the goal of surgery is quite simple. One is to eradicate the disease, restore the hearing, and maintains or restorations of normal anatomical configuration. If let's say you can do it, you should try to aim for restorations of normal anatomical configurations. Okay, what are the factors that determine either you want to do a canal up or canal down? So first is whether you can have adequate access or not. If let's say the patient has massive cholesteatoma involving the sinus tympani or involving the facial nerve, you need to extend it until the digastric ridge, you need to extend it until the cox space. I think better for you to do a canal down procedure. Maximum excentrations of air cell system. Again, if let's say a patient doesn't have a cholesteatoma but having a lot of granulation tissue, and this granulation tissue can give a risk of persistent discharging ear, then you can decide to do a canal wall down procedure despite of patient doesn't have a cholesteatoma. Familiarity with the anatomy. If let's say you are a surgeon and you are clear regarding the anatomy of the facial nerve, please do a proper canal wall down massage surgery. So you need to ensure the stability. If let's say the patient have well normatized mastoid, in pediatric patient doesn't have any history suggestive of complication, it's better for you to do a canal wall up procedure, because the huge mastoid cavity can end up with a persistent discharging ear. So created well sculpted cavity, that means you need to bevel the edge of the mastoid cavity, and either you want to use the obliterative technique or not. So straightforward, canal wall up, canal wall down. So I have a few more minutes. I will do quickly on this. So canal wall up, either eticotomy, eticoantrostomy, cortical mastoidectomy, and combined approach tympanoplasty. Okay, what are the boundaries of combined approach tympanoplasty? Maybe the one that with the red dress from UM. So what are the boundaries of posterior tympanotomy? Yes. What are the boundaries of posterior tympanotomy? Chorda tympani medially. So if let's say you have this slide, so you can say that this is the facial nerve. Okay, this is supposed to be the chorda tympani here. So you can say this is anterior, this is posterior. Okay, so this is the area of the facial recess, and superiorly this is fossa of incudis. So when you want to do a combined approach tympanoplasty, the patient normally doesn't have a good eustachian tube function. So you can give a good aeration by creating a space between the middle ear and mastoid cavity. So now, normally during the viva, we'll ask you how you draw the McEwen triangle. Okay, so this one is wrong. So this is superior temporal line. This is supposed to be the imaginary lines of the posterior wall of the EAC. This is spine of Henle. So this one is wrong. It is not the McEwen triangle, because McEwen triangle is a triangle which indicates the antrum. So the correct one, okay, superior temporal line, posterior wall of the EAC, and this is the line along the spine of Henle. So this is the area of the antrum. So the indication. So if let's say you have patient with the cholesteatoma, modified radical mastoidectomy, if let's say you have patient with extensive granulation tissue causing mastoiditis, also indication for mastoidectomy, or failed canal wall up mastoidectomy. We rarely do a radical mastoidectomy because by definition radical mastoidectomy, excentrations of the tympanic membrane, remove the whole ossicle, you leave the only the stapes foot plate, and you plug the eustachian tube. Okay. So indication is chronic suppurative otitis media with complication. I prefer modified radical instead of radical mastectomy, or fail modified radical mastectomy. So advantage and disadvantage I will skip. But when you look at the post-operative complication, canal stenosis. Why the patient have canal stenosis? So you all can think could be due to improper myatoplasty. Yes, if let's say patient had either post-auricular incision or an oral incision. But if let's say patient doesn't have a short case, doesn't have post-auricular incision, there is no an oral incision, but patient has a canal stenosis, could be acquired or congenital, acquired due to extensive otitis externa, or patient underwent radiation therapy, now having osteoradionecrosis. Still possible. So in other words, you all need to have a very good, effective group study to discuss about the common exam questions. Okay, tympanoplasty, straightforward. Either you want to do autograft, or you want to have a graft from the others, such as from the amniotic, you want to take from others materials, but I prefer to have a temporary spatial graft. The mucoperichondrium, normally I take from the tragal cartilage, and I normally not doing the cartilage because the cartilage you need to have a proper plate or instrument so that you can slice it nicely, and it is more time consuming. Muscle obliteration, normally we will do inferiorly based flap in order to put inside the muscle cavity. So you can either use bone dust, you can either use hydroxyapatite. What happens if let's say you cannot sure that you leave the cholesteatoma? Can you do muscle obliteration? Okay, so muscle obliteration, if let's say you are sure that you remove all the disease, otherwise it will hidden inside the material that you use to obliterate the muscle cavity. How about the opposite ear? So remember last slide that I say that around 7 to 10% patient will have bilateral involvement. So in other words, you need to look at the contralateral ear. So now the question here, if let's say you have bilateral ear diseases, okay, which ear that you want to do operation first? Okay, Dr. Lokman, bilateral discharging ear. So what are the factors contribute to your decision to operate in one ear? Okay. Okay. Not the anatomy that you're familiar with. So in other words, the aim is to look for the worst hearing ear in terms of the disease. When you have cholesteatoma and granulation tissue, you operate on the cholesteatoma first. When you have better hearing and poor hearing, you operate on the poor hearing first. And number 3, you look for the impending complication. Okay, if let's say bilateral mastoiditis, one side with the erosions of the tegment, another one is normal. So you operate on the one that worst radiological imaging that you can see, which can lead patient having a complication. Okay. So now, how about residual cholesteatoma? So if let's say you have residual cholesteatoma, you should aim to do the proper complete exenteration of mastoid hair cell. So revision surgery, I think not many ENT surgeon like me also, I don't like to do revision surgery because it is more difficult for me to identify the landmark of the facial nerve, more difficult for me to look for the disease. Sometimes when you open up a lot of bone tissue or bone, new bone formation, very scary to open up in a revision case. And why you have to do a revision surgery? Because it either high facial ridge, there is also hidden cholesteatoma over the 5 hidden area. Either the patient doesn't have a good eustachian tube function, or there's a contamination from the external ear canal, or the patient have untreatable allergic rhinitis. Okay, it could be need to address all these factors. So you need to have pre-operative CT scan or MRI. I prefer CT scan. If that's leading to complication, I prefer to have CT and MRI. Patient monitoring, and need to have a proper consent. So the proper consent consists of the procedure itself, the risk that the patient may have intra-op and post-op, the hearing, whether this patient end up to have a profound hearing loss. Okay, and number 3, whether the patient had a residual hearing following revision surgery. Sometimes patient underwent 3 operation, 4 operation. How about the only hearing ear? So in other words, when you have the only hearing ear, the aim to do the canal wall down procedure, because you need to exenterate all the disease. You don't want to have 2 risks to do 2 operation, and it is more conservative compared to do a canal wall up procedure and later you do a second loop surgery. Then you look at the muscle surgery in patient with facial palsy. Okay. If the patient has cholesteatoma, present to you having a facial palsy. Pre-operatively, facial palsy grade 3. Okay. So the consent here is to eradicate the disease, to restore the hearing, and at the same time to improve the facial nerve. Okay, so the difference in iatrogenic facial palsy, in this patient with cholesteatoma or mastoiditis, never do neurolysis. You open up, you remove the cholesteatoma, you leave the one that exposed to the facial nerve, you remove the ends of the procedure, the perimetrics of the cholesteatoma, and quickly you put the superficial temporary fascia on the facial nerve. It is different if let's say you deal with labyrinthine fistula. Remember, if let's say you have erosions of the lateral semicircular canal, you will remove all the disease inside the mastoid cavity. Then you harvest superficial temporary fascia. At the end of the procedure, you don't remove the perimetrics of the cholesteatoma. Why? Because if let's say you remove, the patient may end up with the leaking of the perilimb and patient will have dead ear. However, if let's say the patient has labyrinthine fistula, present to you with a dead ear or profound sensorineural hearing loss, might as well you remove after you exenterate everything. Then you prepare the superficial temporary fascia. At the end of the procedure, you remove perimetrics. Then you put superficial temporary fascia. Understand? Because you don't want to have any risk to have recurrence. Okay? Everyone understand? So in other words, when you have patient with a facial palsy, the aim is to improve the facial function. So insyaAllah, if let's say you have patient cholesteatoma causing facial palsy or mastoiditis causing facial palsy, please refer early. Don't say that, oh kita bagi steroid lah for about 2 weeks, 3 weeks. How you want to improve patient, whereas patient already have disease. You give steroid, at the same time, please refer to the tertiary hospital. Okay? Key to success, you should familiarize with the anatomy, working knowledge of ear physiology. In other words, when you want to do reconstruction, you should put something that's in between the absence of the ossicle. You want to look for the tympanoplasty type 3, whereby you take superficial temporary fascia, you put over the stapes suprastructures, so that it can have a normal physiology of transmission of the sound toward the stapes plate. Refine technical skill. So don't say that I already have one chance to do a temporal bone dissection. Please go for 2-3 times. Doesn't matter. We are as as a teacher ni rasa macam besar hati sangat kalau anak murid kita dapat buat dengan baik. Betul, itulah semangat yang orang kata apa, we like to have more people to become pathologists or rhinologists or skull-based surgeon. We are proud to have you all. Adequate equipment, you need to have proper microscope, proper patient monitoring, and at the same time you need to have a proper micro instrument. Don't use the instrument for the face towards the instrument for the ear, different, the size different, and you should audit the result. Pediatric cholesteatoma, this is one of the example. This is well pneumatized mastoid. You cannot say that this is not pneumatized mastoid. This is well pneumatized mastoid, but filled with the cholesteatoma. So you cannot visualize clearly the lateral semicircular canal. You need to look at the different cut. So take home message like Dr. Q mentioned. You can mention that there is a presence of the soft tissue occupying the whole mastoid air cell, extending to the epitympanoid, and I cannot visualize clearly the whole lateral semicircular canal. So this patient having this PTA, the air bone gap is more than 30 decibel. You can see that there's possibility of oscular discontinuity. So ni mengajar anak-anak kita. So we need to harvest a big superficial temporary sphacia in order to place it over the cavity. You can lay this superficial temporary sphacia superiorly, and inferiorly you can lay also the inferiorly based flat. Okay. I also invite those from USM, UM to come to UKM. If let's say we have an interesting case for 1 day or 2 days, I don't think that we need to pay, but you just need to write letter to Prof Salina and say that I just want to observe the facial nerve decompression, or I would like to see the operation done by Prof Marina. Also can, because we are conjoined exam. Okay, post-operative control, straightforward. It's okay, the short six ready? Okay, so I will skip this post-op management. The most important thing, you all need to know that if let's say the patient have progressive sensory neural hearing loss secondary to cholesteatoma, you can have a hearing aid first. Number 2, you can also give an options of cochlear implant after you eradicate the disease. So the current trend, I tried to get this full paper published in 2013, Muaz Bichi. Habib went to the course. Okay. So I not prefer endoscopic because I prefer microscope. Dr. Dina will learn how to do the transcanal endoscopic ear surgery. So in other words, as a surgeon, you need to have 3D dimensional view, patient monitor, good knowledge on drill and types of burr. You need to have a proper understanding on the hemostasis. I will skip this one. So conclusion, I think the surgeon need to match operation to the disease. Either you want to do episiotomy for limited disease, you want to do a canal wall up or canal wall down. You need to also to ask and discuss with the family members either they are agree or not for the second loop surgery. And for us in UKM, we prefer to have canal wall down mastodectomy for cholesteatoma with a type 3 tympanoplasty. So thank you very much. So I will bring delegates from Indonesia to visit this our Prime Minister buildings, insyaAllah this evening. Assalamualaikum warahmatullahi wabarakatuh.
So